to help loosen the tendon. Avascular necrosis, so this is where there's some bone death associated with steroids, alcoholism, HIV, lupus, hypercoagulable states I'd mentioned. So let's look at office miscellaneous stuff. And for some reason, I get a lot of patients who have joint hypermobility syndromes, okay? So they're very, very flexible. And it's possible because I'm hypermobile too. I don't know how many of you can touch your thumb to your wrist, but that's a sign of hypermobility, and you can do a hyperextension of the thumb. That's part of the Baton hypermobility score, or you can take your pinky and bend it all the way down and touch the floor with the palms of your hands. So there are certain genetic collagen disorder. It makes your ligaments very loose, so you're able to do this. A lot of gymnasts have collagen disorders where they're able to be loose. So those Chinese acrobats, they probably have some spectrum of this. Marfan syndrome, you see high arch palates, long limbs. Usually the arm span is longer than their height. Not only that, you see a pectus excavatum. So in patients with Marfan's, you'll see like a deep caved-in chest. Some patients will have spontaneous pneumothoraces. They'll have dislocation of their lenses in their eye. And so a lot of times these patients will be wearing really, really thick glasses. And their palate is very highly arched. So that's classic Marfan's. It's autosomal dominant, basically with variable penetrance. So some patients may not have all these classic signs and symptoms. Ehlers-Danlos syndrome. So this is your classic hypermobility. So they can have a lot of elasticity. Their skin, you can pull it. It's pretty remarkable. They can do crazy tricks like this one gentleman. He's young. He's showing me how he can dislocate his shoulder readily. Oh, I have some other pictures which I didn't put on here in interest of time. But he can just do crazy, crazy tricks. I mean, bringing his leg all the way back to his head like some ballerina. And he's like, I never exercised a day in my life. But we worry about vascular EDS because these patients can have vascular rupture, like aortic aneurysms. All right, I'm going to show you this one case. I think this might be my last case. 23-year-old male comes for evaluation of joint pains. He says his sister has EDS, and she also has POTS, which is postural orthostatic tachycardia. Whenever she stands up fast, her heart rate goes up, and then she passes out. He reports fatigue and pain. You know, he's about 78 centimeters high, so 6'6". His blood pressure is 98/66, and he has a murmur, a diastolic murmur. You have cardiology after me. So this is him. I mean, literally, that was his complaint. My sister has EDS. They told me I got to get checked out. And here it is. Look at his chest. Well, this is his arm. It's 86 centimeters. His height, 78. And look what he can do. He can move his thumb. I don't know if I can do. I can't even do that. All right? What do you think should be done next? Just send him to physical therapy. Refer him to a geneticist to rule out EDS. Order an EKG. Order an echo. Or just give him some NSAIDs because he's hurting. Yes. So this patient has classic Marfan's. So I don't know whether or not his sister was misdiagnosed with EDS, because it's possible she has Marfan's too, just not the height and the arm span because it's variable penetrance. And so in a patient with Marfan's, you worry about aortic root dilation. And when they have aortic root dilation, AR, it's one of those diastolic murmurs, okay? So you've got to know whether or not he is going to need to have a valve replacement because these patients have cardiovascular complications. All right, so I'm going to round this out. I'm going to give you the high points, the pearls. Number one, you remember the truth. There's not one single lab you can hang your hat on in order to make a diagnosis, okay? The second truth, know your patterns. I mean, it's true for any discipline of medicine. If a patient presents a certain way, looks like a duck, quacks like a duck, smells like a duck, it's probably a duck. And the majority of your cases are going to be ducks. There's going to be a few zebras. There may be a few ugly dogs like Elwood, but it's very rare to encounter an ii. Inflammatory arthritis, when there's inflammation, it's prolonged morning stiffness. Mornings are worse. It gets better with activity. You see swelling, you see heat, you see pain, okay? The ANA, don't hang your hat on the ANA. I mean, I make a lot of money because of ANA consults. That means absolutely nothing, okay? So a patient with a positive ANA, think about your whole spectrum of what things could be. It could just be thrown in there to throw you off, a red herring. In patients with rheumatoid arthritis, remember the distributions, your MCPs, your PIPs, symmetrical, okay, prolonged morning stiffness. Whereas with osteoarthritis, you have your DIP joints, your CMC1 joints, okay, and asymmetry. Osteoarthritis is asymmetrical. Lupus. Lupus can kill, all right? If it kills early, it's from the disease. If it kills late, it's from cardiovascular complications. So remember, renal and brain disease predicts mortality, and just don't miss that MI in a lupus patient. Joint fluids, remember the cutoff. White blood cell count greater than 2,000, inflammatory. If it's really, 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 really high, gout or infection, okay? Premenopausal women do not suffer the gout, okay, because estrogen is protective. You see a case of a 27-year-old woman who presents with one hot swollen knee, don't automatically think gout. It could be pseudogout, could be a psoriatic arthritis, oligoarthritis, okay? Okay, FDA recently issued warnings about the quinolones. Quinolones can cause tendon ruptures. I didn't go over this earlier, but just remember that. So a lot of times, you know, you have to prescribe something for an infection. If you could, just be careful and mindful that quinolones can cause tendon ruptures, tendonitis, especially in patients who have one of those seronegative spondyloarthritis or who are on steroids already, okay? Because tendon rupture, when they occur, they're hard to repair. Common things are common. Fibromyalgia is more likely than normal CPK polymyositis. Okay, normal CPK, you can't say it's polymyositis. Fibromyalgia is more common. Usually, and this is the big thing, one rheumatologic disorder per patient. I don't like it when I see a patient has lupus and have gout and have seronegative spondyloarthritis and maybe on top of that has scleroderma. Come on. Usually that's not going to be the case. It's going to be one rheumatologic diagnosis. Patients with temporal arteritis, don't forget to screen them for aortic aneurysms, okay, particularly 3 to 5 years after diagnosis. Patients with polymyalgia rheumatica and temporal arteritis, higher risk for strokes, put them on an aspirin. 90% of back pain without neurologic deficits will improve on its own. Do not prescribe bed rest. Patients with spinal stenosis, lean forward. Patients with prolapsed disc, leans back. Rotator cuff injuries, most common cause of shoulder pain. Baker or popliteal cyst, it can look just like a DVT, okay? If it ruptures, your whole leg, the whole bottom part of the leg could be swollen. Go ahead and get an ultrasound to evaluate for DVT. I didn't go over this, but Morton's neuroma, so this is a small bundle of nerve between the third and fourth toe. It's very painful, particularly if you're wearing high heels. Usually they inject or they take it out. And then just review your dermatomes. So, I finished on time.